Okay, here we go. Now it's on. So it should be going now.
Send the link to people. Gary's asking.
I believe we are live. Okay. The only thing is that my camera is a little bit off, so I'm going to fix that. Okay. Now my OCD is satisfied, so we can start. Good evening. We are live. This is United Medical Diabetes Center, and we are here. Today is August 11th. My name is Kamal Erkan. I'm the chairman of United Medical ACO. I have our program directors and managers and our providers with me, and I'm gonna introduce them, and I'm getting messages, and they are asking for the link. So if you can give me a second. Actually, why don't we do this? So Amy, if we can start with you, so you can introduce yourself, and then I'm going to send the link for the providers.
My name is Amy Wilcoxon. I'm a registered dietitian and certified diabetes educator, and I work with the diabetes program.
And I'm Donna Gunkel. I am the director of clinical integration here at United Medical ACO. This is our Diabetes Wednesday Wellness webinar. And we do this historically for the last year. We've done it twice per month on the second and the fourth Wednesdays. As of last month, we've now converted the fourth Wednesday to a diabetes support group. So you can find out more information about that on our website, or certainly you can contact your dietitian to find out information about that as well. So Kamal, did you want to continue at this point?
Sure. We have Dr. Jennifer Liquido. Tonight's topic is we discussed the diabetes in adult medicine mostly, and then not necessarily we didn't forget the pediatric side of it, but mainly what we deal with is on the adult side. But then we have pediatricians in our groups, and Dr. Liquido, who's one of our frequent host guests actually in our events, and tonight she's gonna be with us, and we are gonna discuss the diabetes in pediatric population. Dr. Liquido, if you can please introduce yourself, and then we'll start the session from that point.
Okay. Well, as Kamal mentioned, I'm Jennifer Liquido. I'm a pediatrician with United Medical Clinics, working in the Smyrna office, and I need to introduce something else. I'm a general pediatrician, studied in the Philippines, did my residency in New York, and now has been in Delaware for, oh my God, let's not say how many years I've been working in Delaware. A while.
You are still very young, so well, thank you for being with us. I'm going to actually open our PowerPoint so we can, Amy, I know you don't like surprises, but by now dealing with me, you are used to this. So I do want to actually just share one little item. So Don and I, in our care coordination team, we do case reviews. Our nurses, we have about 7 of them on the ACO side, and then there are about 5 of them on the bariatric side. So in the last 2 months, we do actually a case conference on a daily basis. So that's about an hour every day, and our nurses present cases to our team, and then we communicate with our providers. And more than half of the time, either dietitian or nutrition is part of the referral process that we have. And because of that, we actually have this new communication, one of the database communication that we are going to start sending to our patients. I do want to, and we're going to improve this, but I do want to share one example of it, since this is going to be circulated with our patients so they can get used to that. And you can also see what I'm talking about. It's going to look like this. It will have one of our nurses' names there. And the title is going to say United Medical Diabetes Education. And then there's the language that we have for our program, and the link will take them directly to our, if I actually click on it, it will take them directly to our wellness program. So then they can actually watch all the wellness videos from Wednesdays. So from one link, they can actually reach out to all of them all together. So my main reasoning for this one is I just want to make sure that when patients are getting this may be on behalf of their providers, but it's going to come from United Medical for the diabetes education. The main thing is for the link to be convenient for them, so then they can easily access to all of our videos for the education part of it. One of the common things that we see is a lot of, not maybe a lot, but maybe 20-25% of the time, we see refusals on the nutrition follow-up. And I was thinking what we can do to help them is, okay, if you don't want to see the nutritionist, can we actually help you in some different ways? And one way is our videos are there tonight. Right now it's 7 p.m. and 4 of us are here to make some meaningful educational videos for our patients. So they can just watch this at their own convenient time. So and we are going to share this for our patients. If we see any, even if you don't see the refusal, we'll still send them that so that they can actually easily reach out to our videos. So we are going to be sharing that with them. Just wanted to share it with you guys as well. So I'll go ahead with the PowerPoint. No, Amy's anxiety is over.
It's okay. I was like, what is happening? Care conference? Are we talking about patients?
It's exciting because we're always looking at ways to make it easier and convenient for them to find the links to all of the videos. So we have it in multiple places. This is just,
yeah, it saves time for me having to email it too. So
Yeah,
I appreciate.
So, and before we start with the session, I do want to mention our medical director, Dr. Rick Mohandal, our physical therapist, Tim Naku, and our social worker, Jackie Tamasari, are part of the program. So, all right, Amy, if you want to take over from this point.
Thank you. So we started last year, since we are no longer able to teach our in-person diabetes classes, our Wellness Wednesday webinar program. So we meet twice a month, and we've changed a little bit, as Donna said, where we do a webinar on the second Wednesday of the month, and we meet with specialists in all areas since diabetes does affect your whole body. So we've had cardiology, nephrology, podiatry, social work, all kinds of things. Our fourth, and we'll talk about the date at the end, our fourth Wednesday of the month is now a support group. So tonight we're taking a little bit of a turn. We're going to be talking about type 2 diabetes in children and teenagers. So we're very excited to have Dr. Liquido with us to talk to us about diabetes in children, since it definitely is a little bit different than in adults. So thank you so much for joining us.
Thanks for having me here. Okay, so we will start off with a little bit of a case presentation. So we just give you a little snapshot of a patient case. So this first one was an 11-year-old Hispanic, presented to the office with vomiting twice a day, diarrhea 4 times a day, about 3 weeks duration. At that point, the vitals and the measurements, you'll see it in here, 296 pounds. BMI percentile at the time was like a 99.76. Blood pressure 129/84. Heart rate was 74. normal rest of the exam. When we checked for the urine dip at the office at the day, glucose was 2,000 and the finger stick glucose was 268. Okay, so that was the first case. Now we go to the second case. Before we discuss, we'll tie it all up together later. This was in another visit, 15-year-old Caucasian, again, presented to the office for a well visit, complaining of some irregular periods, feeling tired on and off, but she's also had a complicated medical history with some seizure disorder, ADHD, obesity, on a couple of medications. At that time, height was 65.25 inches, weight was 182 pounds, blood pressure was 133/88, BMI percentile was 96.7. So again, a little different in adults. With kids, we deal with BMI percentile instead of like the plain BMI number. On exam, hirsutism, so some velvety, no, not acanthosis, sorry, hirsutism on the whole body. So we did some blood work, and as you can see on the next slide, blood work showed fasting glucose of 229, hemoglobin A1C of 9.1, and elevated cholesterol, elevated LDL, elevated triglyceride, and then low HDL level. So both of these cases were referred to a pediatric endocrinologist. Both of them were admitted at the Children's Hospital, and both of them were diagnosed with type 2 diabetes. So the first case, we probably suspected, and they probably suspected also, that it may be a type 1 diabetes because of the presentation. But the second case was very typical of like a type 2 diabetes that we are encountering. So again, I'm sort of revealing how old I am by mentioning this, but when we were in medical school, type 2 diabetes was not a topic that has been focused on in pediatrics. But over the past 20 years, the incidence has been increasing. So this data has derived from the Diabetes Care Journal in January of 2021 by the American Diabetes Association. So they are saying that about 5,000 new cases per year in the US, about 1 in 3 cases of new diabetes diagnosis in children. And the CDC projection is those under 20 will have quadruple, the cases in those under 20 will quadruple in 40 years. So this is something we really should focus on. So as Kemal and as Amy has mentioned, it is a very different from type 1 diabetes and type 2 diabetes in adults. So in such a way that there's a rapidly progressive decline in B cell function. So the beta cell of the pancreas is responsible for producing insulin. So these kids have insulin, but because of insulin resistance, they have more tendency to produce insulin. And then the beta cells are unable to keep up with insulin production, resulting in hyperglycemia. And this would result in accelerated development of diabetes complication. So it's very important that we catch them early. Next slide, please. So most of them present asymptomatically. And so what we need to look for are the risk factors. First is ethnicity. So it's very common in African American population, Hispanics, Native Americans, Pacific Islander, and Asian Americans. And adiposity, obesity, first degree relative with diabetes, females, low socioeconomic status. If you look back at their birth history, the low birth weight and mother with gestational diabetes were also risk factors. And I will say later on why these risk factors are important. Again, clinically, most of them are asymptomatic, so it's very important that we screen them. Some of them may present like type 1 diabetes would present with increased frequency of peeing, very thirsty, eating a lot, but losing weight. Acanthosis nigricans, this is one thing I was mentioning earlier, velvety, dark skin, especially on the neck, on the armpits. Some of them would present with full diabetic ketoacidosis. in which they have high glucose, ketosis in the urine, acidotic breath, and electrolyte abnormalities. And some of them may also present with typically the type 2 diabetes in adults with hyperosmolar hyperglycemic syndrome, in which they have extremely high blood glucose causing severe dehydration. But usually this is like over a period of time. So since they're quite asymptomatic, it's very important for us to screen. So what we need to do is risk-based screening, usually after onset of puberty or 10 years of age, whichever occurs earlier. So risk, of course, will be obesity. If they're obese, 95 percentile for BMI for age, go ahead and screen. If they're only overweight, 85th percentile, or about 120% of ideal body weight, with a couple of risk factors, which we discussed earlier, then go ahead and screen. So with screening, can we have the next slide, please? We can do the random plasma glucose, fasting blood glucose, oral glucose tolerance test, or hemoglobin A1C. So these are the values that would reflect a possibility of the diagnosis. Now, if they are normal, you could repeat the test every 3 years, or you could repeat it more frequently if the BMI or the BMI percentile is jumping every year. Now, the other labs are used to differentiate it from type 1 from type 2, so that usually with kids, the pediatric endocrinologist would order the fasting insulin, C-peptide, and autoantibodies to make sure that they're not type 1s. So a little bit of the management, and I know Amy will also touch on this. Very, very big and very, very important is lifestyle modification. So they read the diabetes journal actually say like moderate to vigorous exercise. So it's not just plain walking around the block without exerting any effort. So 60 minutes a day. And for kids, very important to emphasize limiting screen time to less than 2 hours a day. Because if you don't limit it, they will not do the vigorous exercise. And then, of course, referral to a nutritionist. Medication, usually either metformin, or sometimes if they're too bad, they start on insulin. And then later on, they can be titrated down to an oral medication. And this is sort of like a very dramatic diagnosis for kids because it's a chronic illness. So it's important for them to understand that it may get better, but it's not going to go away. So psychologist is a very important part of the team, diabetic educator and a social worker. And of course, we need to involve the school. They need to know that the kids are having this and 504 plan for school so that they know what to do just in case they have problems. So for counseling and education, it needs to be family-centered, okay? Because again, if the family's not involved and they have a lot of things that are bad for the kids, it will not be a successful management. It has to be developmentally appropriate so that kids would understand what they need to do, need to be sensitive to family resources, and it needs to be culturally appropriate. Again, example for Asians like us or for Filipinos, we are used to having white rice for breakfast, lunch, and dinner. So if you are dealing with that, it's important that, the clinicians and the educators and this understand what they have at home and what they usually eat at home. And we need to consider, of course, as with adults, we need to consider their health literacy and financial barriers and social supports that has to be in place.
I think this is where they can actually get the most benefit out of the nutritionist when they work with the nutritionist directly, right?
Yes. Yeah, very important. Again, like, not we can say all these things, but in the end, we need to know what the patients are dealing with at home. So short of like really visiting them in their houses, asking them what typically the family eats, what's in the refrigerator, what are the typical snacks. We need to start with that instead of dictating to them what they need to be doing. So we need to give them alternatives. We need to give them how they can modify it and how they can make things better. We need to teach the parents or the caregivers what to shop for, what are the alternatives, what are the snacks that are better. And it needs to be gradual. Again, there are some cases actually that way back in residency, and I didn't know this, we expound like, okay, this is what you need to eat, but the typical snacks that they have on the Asian population may still be different from Filipinos to Indians to it's a vast variety of what they have at home and what they want for snacks and what they have for every meal, which we need to address. And then again, for monitoring, like every 3 months, glycemic the glycemic levels, hemoglobin A1C target is usually less than 7. And then, as we mentioned earlier, they can progress rapidly to complications. So eye doctor visits for retinopathy, screening their urine for microalbuminuria, doing blood work to check for lipid levels, checking their blood pressure, and then also asking how they sleep, because sometimes they can also present with, they can also have sleep apnea, and checking their labs, making sure they're not developing fatty liver. And for females, since it's common in females, also comorbidity of PCOS. And then so far, we've never had a case like this, but again, it may be metabolic surgery, may be something that may be needed for those with severe obesity that are not responding to diet and nutrition and whose diabetes is worsening. Do we have another slide? I think that's it for.
Yeah, I think that's.
That's me. Kamal, did you want to talk?
So now, 2 patients that you shared, one of whom I just want to make sure that we didn't make any mistakes. One of them is an 11-year-old. That's buddy. Okay, but just let it out. Okay, one of them is an 11-year-old, 296 pounds. The other one is a 15-year-old at 182. Now, I think Delaware was, if I may be wrong with the obesity level, I think it's either number 2 or number 3 of the population with the, not morbid obesity, but obesity at 35%. I may need to check the numbers, but when you were explaining this from the type 1 to type 2 and how that's changing, I think with the obesity level going up and the eating habits are being different now, access to food and what type of food you are eating, now the uncommon type 2 diabetes in pediatric is becoming more common. So in the beginning of the call, I was actually really just saying that maybe unknowingly, because while we were not doing a lot of diabetes and now in pediatric, and now we are kind of seeing it a little bit more, I think that explains it a lot better. Because we have, the kids are not, the kids over 10, 11, 12, they are almost in adult sizes.
Yes.
So, now that explains. Now, one other question that I was going to ask you with the 504 school plan, does that include anything other than, is it specific to the diabetes, or is there some protocol that kids with different disease?
And anything with this, anybody who needs a little bit of a special help.
Like so if they have allergies.
It's just an action plan for school. So people with diabetes, those with seizure disorders, even kids with ADHD can have a 504 plan.
Now, one other question which I was kind of mentioning earlier, and because we are actively, Don and I, we are actively on the case conferences, and sometimes we call the patient during the case conference. This, the objection to the counseling of the nutritionist, and from the provider standpoint, from the physician standpoint, what do you see that, how can we overcome that problem? Because this is not a financial reason that we are reaching out to these patients. We want to actually complete the care that we started. And it does, to a point, it does bother me that, like, why would they not going to use this help? And then especially now with the telemedicine, we are able to provide this without them leaving their home. And honestly, all the education that we have in different areas of the medicine, we need more education, and we need this from you guys, from different professionals, and we can do it without that. And how can these patients who are struggling with these diseases, how can they actually deal with them without getting this help? So I just don't understand that part. Do you have any maybe suggestions that we can approach them differently?
Actually, yeah, that's something that we are having difficulty with in the office. Of course, we do our part in telling them about diet and exercise, but of course we recognize the fact that they need something a little bit more extensive. So actually lately, just because of the availability of telemedicine, a lot of them are a little bit more open to it. But one barrier will just be discussion of weight. Okay, so when you bring up the weight, there's already that, it's either they're very resistant, or with the parents, they're afraid to bring it up to their children. It may trigger some psychological things, so you have to balance, how accepting they are, because you don't want to trigger like some psychological aversion to eating. That may be underlying. You need to see how some of them would feel like, they know all about it, right? Are quite resistant to a third party telling you another thing or the same thing over and over again. The most successful thing probably that I'm showing is when I show them, okay, this is your blood work. Okay, so we're not just dealing with weight. So you have this cholesterol is high, and where you're getting this from. So we tell them that we just need to identify things that you may not know, maybe the sources of why your blood work is like this. That's one thing. Second thing is, asking about the relatives that they have who have problems, So if they're seeing, okay, do you see them like having difficulty, going to the doctors a lot, or injecting something, those would have insulin, would open it up that, I always tell the kids, like, your body's young. It's like a young car right now. Okay. It's functioning well. You're not going to feel anything right now, but like 10 years, 14 years, 15 years down the line, it's going to break down. Just like an old car. So sometimes it gets to them like, oh, okay, like maybe I need to listen to you. But yeah, you really have to go down on a personal level. And in primary care, we have a little bit of that, I guess, a little privilege, because most of them we know growing up, we know the families. So hopefully if we can connect to them at that level, then we can convince them. But it's still very difficult, honestly.
I was going to say, children and even adults, because when you ask the question, Kamal, I know Amy and I've had this conversation many times. Sometimes it is a stigma, right? That they're like, I don't need somebody else telling me what I already know.
Yes.
And I know about my weight. I know about this. I know what I'm supposed to do. I know Amy hears that a lot. I know what I'm supposed to do. I just don't do it. So sometimes it's like, even with other things, they have to be ready for the change. And if they're not ready, I think that's when we find that people are more resistant, Kamal, or where they will not want the help because they're not ready for it yet. But then we find other people who may not have been ready a year ago, but now they are, or they've started on their own and now they want help because now they're motivated. Like the lady we had on the support group,
Yeah.
she got motivated, right? She has made a lot of changes in like the last 8 months, and she wanted to be on the support group, and she wanted to even find out more from other people and what they're doing. So again, I do think it is where they are right now or where they are when we reach out to them. But at least if they know and we send a letter and we've made contacts, or maybe we've sent them your new email and links, at some point, it may not be today or tomorrow, might be next month, they can go back to that, and then they can always call us back, and then maybe that's when they're ready.
And I think Dr. Laquita made a really good point. When I meet with people, I don't talk about their weight usually first thing at all. And I might say, oh, have you gained or lost? But because I know that if they do need to lose weight, and I'm addressing eating for cholesterol, blood sugar, they're going to lose weight if they make those changes. But the fact that I don't even talk about setting weight goals, I think is so refreshing, because they feel like I'm going to yell at them about their weight and lose weight. And instead we're talking about more what to eat versus what not to eat. And then it's, oh, all right, she's not so scary. This isn't so bad, after,
well, I guess,
being a BMI card.
Yeah, that may be because when they feel, when they know that something is not right, and then when they have a meeting or counseling or appointment about it, like, and I'm not going to mention names, of course, but Don and I, we had a meeting today with one of the clients, and we requested the meeting, and the client was already on the fence saying that, oh, he's going to yell at us. I'm like, no, we are here to help you, and we want to communicate our findings. So, but it took about 10, 15 minutes to get them out of the defense mode, because the idea was, we are here to help you. So, but they were not able to hear us for a while, right? Like that's kind of blocking people to hear us. And we really want, this is kind of, from the nutrition and dietitian standpoint, it's a competing service, and it's not financially driven. It's a long-term, we have long-term goals for the population that we are managing, and we want everyone to take advantage of that. Amy, I know you have a couple slides that you would like to share, right?
Okay, so let's talk about nutrition counseling with kids and teenagers. So you do really want to have all of your support group, and you want to have a team. And we do, in my experience with children with type 2, usually somebody else in the family has it, right? Dr. Laquita, mom or dad, or mom and dad, grandparents. So parents are familiar. And this is where sometimes it's tricky, because sometimes the parents know they're not quite doing what they're supposed to be doing. And as Dr. Laquita talked about, it comes on really fast in kids. So if I have if mom was diagnosed at 40, her symptoms might be more mild, and it's not, versus her child diagnosed at 15, where she's going to have some more serious complications early. So we really want the whole family to work together, and the whole family making appropriate changes. So it's something, these kids are still growing, brains are still developing. We don't want any short-term diets. We don't want to do keto. We don't want to do Atkins. We really want to teach kids how to eat and how to cook. So my first job as a dietitian was at Nemours in pediatrics and in diabetes. I still work at the University of Delaware. And I also worked in pediatric long-term care. So I've seen kids and I was a teacher before I was a dietitian. So I've seen kids in all different settings of eating. And I've worked with teenagers and young adults who don't know how to make a sandwich, much less how to boil water to cook something. So we really want the family to work together to learn how to eat. And family to make changes as appropriate. And as Dr. Laquita said, slowly. So if I have a family that eats at McDonald's every night, and they're doing school lunch every day, or parents are eating at work, I can't expect them to start cooking these huge meals for breakfast, lunch, and dinner every day. We have to start with short, smaller goals. Okay, can we add a vegetable to this takeout? Can we change this takeout to this type of takeout? instead of getting a large hoagie, can we get a smaller with whole wheat and turkey instead of salami, and making these gradual changes rather than saying, I want you to, stop eating bread or anything like that. So we do want to do family changes slowly. Thank you. So as I said, gather the team. If social worker from school, teacher is needed, parents, grandparents, brothers and sisters. We don't want to single the poor kid out who's been diagnosed, because really anybody with diabetes, we should all be eating the same food. So the diet for diabetes is really a normal, healthy diet. It's not special. It's the way that we're all supposed to eat. We know that with kids, that if you tell them, well, you're not going to be able to see and you're not going to have any teeth, they don't believe you because it seems so far away. So when they hear that, they, well, it's not happening to me now. And I feel fine, as Dr. Lupita said, they don't have any physical symptoms. So the fact that you're telling them in 10 years, they might lose a toe, well, that just doesn't really seem possible. So we want to see, how can we do this? And we've had people do charts where they, okay, if you exercise every day, we can take, all these miles that we've gotten, and we can take a family trip. If it's 250 miles, where can we go that's 250 miles away? What do we need to do with school? Are you eating school lunch every day? Is there a way to pack every day to get something healthy? Are you eating breakfast at home and at school? So how can we stop that? So there's just one breakfast in. Is there snack at school? Should there be snack at school, but there's no time? So for our younger kids who are not really, they're stopping to gulp down some fruit snacks at lunch, but they say they don't have time because they're busy talking. What can we do to make them be able to eat school lunch? And again, we can't expect kids to make healthy choices if we're not modeling them. So if I have a 15-year-old with diabetes and I'm making them some grilled chicken and broccoli and brown rice, but I'm sitting here eating my cheeseburger and French fries, it's not really fair. So ideally, we're all eating that same food together. So working with the family, what are the foods you're eating now? As Dr. Liquida said, one of the things we always do in a visit is we get a food recall. What are you eating now? Because I'm not going to expect, again, my fast food eaters to go straight to something like grilled chicken and brown rice. Can I have the next slide, please? Thank you. So insulin resistance so lowering blood sugar is important, but also lowering insulin resistance and making the body's insulin more sensitive. So insulin resistance is increased by refined carbohydrates. So a lot of times people think no carbs, no carbs, no carbs. I can't have carbs. I can't have bread. I can't have cereal. Kids eat cereal. They eat bread. They eat snacks. They eat a lot of carbs, but we want them to cut back on the refined carbs. So remember, we want them to be active. So their muscles are going to need carbohydrate, but I'd rather they have an apple than like a Chewy bar. So a better carb. So refined carbs are things like white bread, juice, soda, sweet tea, lemonade, soft pretzels. So in the process of preparing the food and the manufacturing, the outer layer of the plant is stripped. So you just have sort of the simple white flour. They have vitamins back in, but it's not really giving you what you need. So what happens is you have quick digestion, quick energy, and then the body makes a lot of insulin to get it out, to get it into the blood. Into the cells to do work. So again, what's a refined carbohydrate? Any sugary beverages. This is the first thing that we want to stop. And I will explain to patients and to families, 4 ounces of juice or soda and 100% juice, we have to make that clear. That's going to raise blood sugar very quickly. That's what we give you if you have low blood sugar, like for the kids starting on insulin. So we don't want that to happen. So what else can you drink? We really, really want to steer kids towards water. I don't want kids going from soda to diet soda, juice to Crystal Light, because I don't want a 10-year-old drinking mountains and mountains and mountains of artificial sweetener. I don't know what it's going to do in the next 30, 40, 50 years. I understand that occasionally they might want to have a diet Sprite or something, and occasionally I think that's okay, but we really want to steer towards water. And then items made with white flour, so things like crackers, bread, cereal, pancakes, waffles, that type of stuff. We want to cut back on those and eat more natural sources, so like oatmeal, You want to do a good whole wheat bread for sandwiches, things like nuts and fruits for snacks, and peanut butter instead of things like pretzels and potato chips and stuff like that. We're all going to have cake occasionally. We're all going to have cookies occasionally and ice cream. It happens, but we want to cut back. So we want to say as a portion, as a family, we're not going to have these every night. Maybe we're going to have some fruit for dessert. We're going to have these occasionally as a small family, and maybe we're going to walk to get our ice cream if that's something that we're going to do. In our food supply today is really unfortunate in that it's, well, I have to give up ice cream so I can have keto ice cream instead. But that goes back to that diet product. So if we do that, we're teaching our kids that, okay, I gave up my carbs so I can eat all this other stuff. Well, we don't know what that is. And again, you're not getting in the good stuff. What we're really looking for is fiber. So the last one I left out is white rice and pasta. And Dr. Lapita talked about white rice for breakfast, lunch, and dinner. And I say to my rice eating patients, which there's a lot of them, like 75% of the world eats rice, and quite a few do for breakfast, lunch, and dinner. And white rice to brown rice is it's not the same, and the texture is not the same. And I think, when rice is so comforting, it's in every meal, maybe we can cut back on the rice. Maybe we can mix white rice and brown rice together, and we can pair rice with a lot of vegetables. So you're still getting in that comfort rice, but because you have all that fiber with it, your blood sugar is not going up so fast. So we don't want to say, oh, your food is all wrong. We want to say, how can we fix it so it works for you? So I talked about this briefly before. You should not be cutting carbs out, especially from children. They really need them. Their brains are still developing, and we want them to exercise. So again, we're looking at cutting back on refined carbohydrates. We want good nutrition. You don't want to develop disordered eating habits or dieting, leading down to a history of dieting. So we want 40 to 50% of calories to come from carbs. There should be a carb with every meal. And with insulin, we do typically teach carb counting so we can match insulin to carbs, but with oral medication like metformin, we typically don't. So we want there to be vegetables, low-fat milk, yogurt, but not sugary yogurt, so very low sugar. We want fruit, we want whole grains, starchy vegetables, things like peas, potatoes. I really like the little potatoes because you get a lot of skin. Brown rice mixed with some white rice. We need to. Whole wheat bread, sprouted bread. So those good grains, those are the things that we want to have. So instead of having Fruit Loops, we want to have something like Cheerios or whole wheat bread. We have a person who's not ready. The thought of Cheerios is, ooh, can we mix them and do Cheerios, do Fruit Loops and Cheerios mixed together to cut back on it. Next slide, please. Thanks. So again, meals should contain fiber. We always want to have some kind of fiber, and that doesn't mean Fruit Loops with added fiber because that stuff is all out there. We want to have the real deal. So fruit, vegetable, whole grains, and we want a lean protein. One of the things that I didn't talk about with insulin resistant is that saturated fat, so fatty meats that are not good for the heart, can also increase insulin resistance. So we want a good lean protein, chicken, fish, peanut butter, nuts, eggs, moderation eggs. So we want to keep generally healthy foods. So sitting down with the family, what are they eating? What can we plan? So these are some examples: oatmeal made with not a lot of sugar, or they do make low sugar oatmeal if we have a family who's used to eating maple and brown sugar. Made with fruit, nuts, or apples on the side. Vanilla Greek yogurt with a parfait with berries and walnuts. A turkey sandwich. Popcorn is it's a whole grain. So it's something you're getting in fiber. We just want to have it without a lot of stuff in it. And berries, things like string cheese for a snack, apple and peanut butter, carrots, guacamole. Oh, I'm sorry, or Turkish yogurt. Every time I have the Greek yogurt, I get in trouble. Turkish yogurt also. In working with kids, one of the things I always recommend, if it's possible, if it's affordable to pack lunch, to look at the menu for the week. And so I want your kid to pick the day that they really like the best and then pack the other days. So the other days you're definitely getting in some better choices in terms of fruits or vegetables. If you look at these healthy ideas and you think, I can't afford this. I don't even know where to start. Sit down with it. That's what we're here for. So we can go through and say, okay, what can we do that's affordable? if you're used to eating out every night and the thought of, well, I can't afford to buy this chicken and these vegetables, it's too expensive. We can go through and see, all right, we can start with frozen vegetables. We can rinse off canned vegetables, the little things of fruit that are canned in their own juice. Let's start with that if you can't afford to have regular fruit. So this can be all doable, and it's something that we can help you with. Next slide, please. All right, so this is the plate, and then I'm going to talk about not the plate. So I'm just briefly on this one because I've already sort of talked about this. So lots of vegetables. So when I would say, like, if here's your starch, this is your vegetables. So you want your vegetables to be twice as big as your starch. You might not have fruit for the meal because you might not have fruit with dinner. So water, this is for adults. Actually, I didn't like the kid one, so I didn't put it on. It says limit milk or dairy. We do want kids to have milk. Milk has carbs though. So glasses, an 8-ounce glass of milk is a serving. So this is a 16-ounce cup water. This is typically what people have on their table. So drinking this much milk is going to raise your blood sugar. So I don't have a smaller cup down here, but about half the size would be about what you would want for a glass of milk with no sugary beverages. Then you have your whole grain starch, and then you have your lean protein. So part of the reason I do like this plate is because they do say for your protein, you want things like beans and poultry and fish and nuts, and not a lot of red meat, not a lot of bacon, cold cuts, processed meats, because those are the meats that are going to increase insulin resistance and they're bad for your heart. Next slide, please. A lot of people don't eat their food like that, where it's all separated. A lot of people, all their food is together. So this still works. So if your family's making soup, if mom is cooking and everything goes in together, you can still eat this way. So if you think about, all right, well, my vegetables have to be twice as big as my rice. So that means I might have to cook less rice because everybody needs to eat less rice or pasta or whatever the grain is. And then I need to cook more vegetables and think, well, my family's not going to eat all this broccoli and tomato or spinach. So maybe we'll have a salad on the side. We'll have a separate vegetable. So things like stir fries, again, are all together. So we always want to make sure that we're making extra vegetables. A lot of people don't like vegetables. So this is a learning curve. We want to just keep trying. So I did my thesis a long time ago on picky eaters. And back then, and again, it's a long time ago, the research was the average parent tries things 3 or 4 times for their kid, but it really takes 15 to 20. And it may be less. I don't know now that people are trying less, Dr. Lucrino. Now the parent of a picky eater, I can exactly see where this is coming from. So if your family now is making all these changes and everybody's grumbling, you just have to keep trying. And if they don't like raw broccoli, maybe they like it cooked. Maybe you can sprinkle some Parmesan on it. Maybe you can grill a vegetable. So just keep trying. And one day something will pay off. Next slide, please. So again, changes for the whole family. So if you start this whole thing with your family, but then you have a pantry full of Cheetos and fruit snacks and fruit roll-ups, and you guys get the picture, Doritos, how fair is that to your child? It's not fair. They're going to come home from school hungry and, well, I'm supposed to have an apple, but everybody else is having Doritos. How fair is that? So those foods are still allowed to have. You don't want to restrict and completely ban these foods because then you might find all these wrappers under their bed. But it's something that having this honest talk about, it's okay to have these foods in small portions. So maybe we get a bag or 2 that we keep, small bags, and we get 2 for the week. And this is what we have. When we're done, we're done. And then having healthy options that are easy. If you know your kids are not going to chop up something or wash berries or grapes, have them ready to go for them. So it is easy for them to grab. Eating together as a family is something that when I was teaching, people were talking about, and we're still talking about it. So I think I said this in a webinar before. When I was teaching, we used to say it was so important to read to your kids. And now I say it's so important to eat with your kids and teach them how to cook. So going through, involving them, what should we have? What new vegetable do you want to try? Can you help me cook? Set the table. And then going through, this is pretty good. And this is not my favorite. And as I tell kids, every meal isn't going to be your favorite. That would be like if we were in Disney World, but it's just not like that. So ideally, once a week, you get your favorite. Sometimes it's pretty stressful if you do have an underweight child and you have an overweight child and you're very aware, okay, everybody has to eat all these healthy foods, but here I have this kid who can't seem to keep weight on. You can feed them the same foods. I mean, so when we have underweight children, we give them protein, we give them fat to get weight on. So if we're fixing, let's say back to the rice, I can add in some extra butter to my underweight child's rice, and that's going to help them. I don't have to put that in across the board. So they can absolutely eat the same foods. You don't have to single them out. It still can work. Because again, the food for people with diabetes is the same as everybody else. Next slide, please.
Next slide is, I thought it was a question.
No, I knew I had one more. So long-term changes. It's very overwhelming when this all starts, especially if your child is very sick. It's really, really overwhelming. Oh, they're sick. I don't know what to do. I'm going to go home and throw out all the carbs, and it's a 3-hour trip to the grocery store. But I don't want you to do that. I don't want you to go home and throw out the carbs. The 3-hour trip to the grocery store might be necessary if you're not used to reading labels. But you want to encourage these small things. All right, what's a healthy breakfast that you think you would eat, that you think you have time to eat before school? Are you checking your blood sugar? So looking into continuous glucose monitoring. So that's something they could wear. One of the things we used to really see is kids weren't checking their blood sugar at school. We'd say set an alarm on your phone, but their alarm went off at class and they'd be in trouble. So if this is something they can just see how it's running and they can see, oh, when I eat that, my sugar goes up. And then we do often recommend rewards. So if it's, if you've done, okay, I did this every day this week. I checked my blood sugar every day this week. I ate my vegetables every day this week. Can we do this as a family? New shoes, a day out. So we used to do shoes with little pieces cut out. And so every time you either walked a mile or exercise, you color in a piece of the shoe. And then where your shoe was colored, you got to go on this trip to however many miles were made. So we know that positive reinforcement works. We talked about their kids aren't so threatened by like dialysis and things like that, but they do get excited. And be cautious. So I usually say don't promise them a new car because that's probably not, it could be in your budget, but it might not be. So think realistically, what are you actually going to give them? And then again, good eating habits for life. So we find that when parents are dieting, unfortunately, we're not teaching our kids our great habits. So we want to get in, again, good, normal eating. All foods are allowed. We just have to watch how much and how often, really. And then again, meet with your RD. We're here for you. And then psychologists, social work at school, get your team together. And that was my last slide.
So there was a question, and I actually posted a link for that. Do you guys have any opinion on the best non-dairy milk? Is it like, I used to actually have almond milk. Is the soy milk better than the almond milk?
Did you say the best non-dairy milk?
Yeah.
Oh, so for children, I don't like almond milk. I don't recommend it because there's no protein in it.
Okay.
So either soy milk.
For adults?
For adults, it depends again if you're going to, so I don't eat a lot of meat. So I generally don't use almond milk because again, like it's a missed protein opportunity. If you have somebody who's on a high protein diet or a big meat eater, it's fine to do the almond milk. You want to make sure it doesn't have sugar in it. So I like soy milk, almond milk, rice milk. I used to feel is sort of deficient. There's nothing in it. You're nodding your head. I know when I first started working, rice milk was it was soy milk and rice milk. So if you're allergic to soy, you had to have rice milk. That's all there was. And then there's all these new milks. So there's one of the ones I really recommend is pea protein milk is another one because it is a good source of protein. And people tend to like it, except for when I say that it's made from peas and they get a little.
Great, thank you. That was a question actually from my side. So, okay. So Dr. Liquido, today CDC came out with the recommendation for the vaccination for pregnancy and breastfeeding, the risk for those who's breastfeeding. And I think they kind of clear the air in terms of the risk factors. So we are going to discuss this on Friday at our Friday 12 noon sessions, but there are no issues for people who are pregnant or maybe going through pregnancy, maybe planning to get pregnant, or who are breastfeeding. So the vaccination is no problem. Do you have any new information on that one?
No, I just know that their website for like since the vaccinations have started, they were updating like how many pregnant women and breastfeeding women have been vaccinating. So they've been very good at that. And I actually have like a personal friend who's pregnant and who got the vaccination, and they get a little bit more extensive follow-ups on their apps. So very good.
I mean, I don't want to sidetrack, but before since we have you on this session, so I kind of was taking advantage of you.
That's a good point, because that was a real big reason why a lot of women in their 20s and early 30s did not want to get vaccinated, because they were afraid that they would not be able to get pregnant, when they were ready. So now that there's a little more data out there, I think it's good, because potentially, some of those individuals may feel more comfortable now in getting the vaccine.
So, well, this session, as usual, we have a lot of information, a lot of good stuff we discuss. I think one of the underlying issue that I always tell our providers and when I'm able to talk to the patients or our team, to understand patients' home environment to better serve them, because if you don't know what their home situation is, our help is limited. If you don't understand their cultural background, eating habits, it's always difficult to help them. So if we just go by the cookie cutter approach, it's not going to get us anywhere. So that's one of the reasons that actually we started with the case conferences. So then we are actually getting these presentations, so that we don't want everyone to get the same phone call from the care coordination team, because if the patient has Parkinson's disease and then now they are due for nutrition visit, so having that discussion with the patient may not be the best approach, but the caretaker may be the right approach. There are so many different ways to understand what the patient is going through, and the kids is a different population, and by default, parents are always there. So I think the challenging part is those adult kids who are already more opinionated than the adults. And then now you have their parents, and now they have internet. My nephew was with me for 2 weeks, who's 15, and I kind of see like he knows everything and he's 100% sure. And I'm like, look, I work with so many doctors, so I don't need to actually argue with you. So you are right. Whatever he says, I didn't argue. I said, I'm not going to even go there. And he gets upset because I'm not arguing with him. So working with that population is difficult. So, but that's why we want to make sure that our patients understand that we have all different specialties are there to help them. So it's the team approach. And I think we have best dietitians, nutritionists in our team. Amy is one of the greatest, Fran, Beth, they're all great. And just doing this event twice a month, 7 p.m., just that itself is so great. And Dr. Likido, I know this is already late for you. I don't know if you give up your tennis game tonight, but thank you for joining us. And if you have any closing comments.
Focusing on kids.
All right. Well, any closing comments?
Just about our next events. So on August 25th, the fourth Wednesday, we have our next meeting of our support group. And we're going to be talking about staying on top of your numbers, how it can be really easy to sort of, I don't think my blood sugar is going to be good, so I'm not going to check. So we're going to talk about how to get back in that mindset of checking. And then our next webinar is September 8th, so a month from now, and that is with Dr. Hundle and myself. He's going to be talking, it's our next part of the series on diabetes medications on the next class. And I'm going to be talking particularly about certain types of food, particularly less processed carbohydrate and fiber. One of my favorite topics, as everybody knows, I'm always talking about fiber.
So if you want Donna and I to check our blood sugars, we can be your get paid. So I'm volunteering Donna, but why not? So, all right. Well, thank you so much again. Thank you for being with us, and we'll see you in 2 weeks. We do have the United Medical ACO event on Friday at 12 noon, every Friday. Otherwise, for the diabetes, we'll see you in 2 weeks. Thank you so much.